Okay, welcome back to the deep dive. Today, we are plunging into something absolutely fundamental to human health, yet incredibly intricate when things go wrong. We're talking about how we manage air, getting it in, and clearing things out.
Exactly.
This deep dive is all about tackling two powerhouse symptoms that send countless people to the doctor every single day. The feeling of breathlessness or dyspnea, and that sometimes persistent, sometimes protective action we call cough.
Right. And these aren't just simple complaints. They're complex manifestations of underlying physiology gone awry.
Mm-hmm.
And to truly master your understanding, to get to that elite level of professional insight, you need to go deep. Deep into both the biological mechanisms and the systematic clinical approach to figuring out what's happening.
Exactly. And our source material for this deep dive gives us the perfect blueprint for that mastery. We're working directly from a key chapter, Chapter 38, which doesn't just skim the surface. It lays out the fundamental mechanisms of these symptoms, explores the vast landscape of their potential causes.
Yeah, it's pretty comprehensive.
Details how we assess and diagnose them, and walks us through the current strategies for treatment.
Our mission here is to really dissect every essential concept presented in this text. We want to pull out those vital nuggets, those nuances that separate a basic understanding from the kind of depth that allows you to truly grapple with these challenges in a sophisticated way.
Think of this as your shortcut, right?
Kind of, yeah. A shortcut to seeing dyspnea and chronic cough through the eyes of someone who truly understands the mechanics and the clinical puzzle involved.
So let's roll up our sleeves. Dyspnea and cough seem deceptively simple on the surface. I mean, everyone knows what it feels like to be short of breath or to hack, but their roots can be astonishingly diverse, stemming from issues anywhere from the brain's control centers to the tips of your toes, really. Mastering the approach to them, understanding why they happen and how to figure it out is absolutely crucial for anyone aiming for that deep professional knowledge. Let's unpack this material from Chapter 38. All right, let's kick off this deep dive by focusing on that often distressing symptom, dyspnea. As our source reiterates, it's that subjective experience of breathing discomfort. It's a core way the body signals distress related to the respiratory or cardiovascular system or, sometimes even other issues entirely.
And one of the first big challenges the source highlights, which is critical clinically, is the concept of multifactorial dyspnea.
Oh, yeah. It's rarely neat and tidy, is it?
Right.
Especially in patients with established disease.
Right.
You might have someone with clear evidence of significant chronic lung disease and coexisting heart failure. Now, when that patient complains of worsening breathlessness, teasing out how much is coming from their lungs and how much is from their heart, well, it becomes incredibly tricky.
Particularly if treatments aren't working as expected.
Exactly. Especially when their symptoms aren't responding as expected to initial treatments targeting just one system. That's a big clue.
Yeah.
Something else or something more is going on.
This is where the source introduces a powerful diagnostic tool that really helps cut through that complexity. Cardiopulmonary exercise testing, mercifully abbreviated as CPET.
Yeah, CPET.
Why is this test so indispensable in those knotty, unclear cases?
Well, CPET comes into its own precisely when the cause of dyspnea isn't apparent from resting tests. Or maybe when it seems disproportionate to the known severity of a single disease. Or, like you said, when multiple potential causes like both pulmonary and cardiac diseases are present, the value of CPET is that it objectively measures the function of the respiratory, cardiovascular, and even muscular systems under stress during exercise. Rest often hides the limitations, doesn't it?
Right. Exercise brings it out.
Exercise exposes them. CPET allows us to see which system is failing to meet the demands of increased activity. It really stresses the whole integrated system.
Okay, so it's about seeing the body in action. What does undergoing a CPET actually look like for a patient? Is it like running a marathon?
Hey, not quite a marathon, no. The source describes it as incremental, symptom-limited exercise. The patient is typically on either a cycling ergometer or a treadmill.
Okay.
And the workload, the intensity of the exercise, is gradually increased in steps. The patient continues until their symptoms, usually dyspnea or maybe fatigue, limit their ability to go on.
So you push them to their limit.
You push them to their symptom limit, yeah. It's pushed to the limit of their capacity.
And while they're exercising, what kind of data are clinicians collecting? It sounds like it goes way beyond just, heart rate.
Well, absolutely, way beyond. They're capturing a wide range of physiological signals. The core measurements involve ventilation, how much air is being moved in and out, and how the breathing pattern changes with workload. They're also measuring pulmonary gas exchange, tracking oxygen uptake, VO2, and carbon dioxide production, VCO2. This allows them to assess how effectively oxygen is being extracted from the air and delivered to the muscles, and how efficiently CO2 is being cleared.
Okay, efficiency of gas exchange.
Exactly. And the source also notes that in some settings, more invasive or even advanced non-invasive techniques might be used during CPED to measure things like pulmonary vascular pressures or cardiac output directly. That gives an even deeper look at the circulatory response to stress.
Wow, that's a wealth of data. How do you take all these numbers, particularly those captured at the peak of the patient's exercise capacity, and use them to definitively say, okay, the primary problem is here in the lungs, or no, the primary problem is here in the heart? How do you tease that apart?
This is where the expert interpretation of the CPP results is absolutely critical, and the source provides some key patterns to look for. It's about pattern recognition, really.
Oh.
If the findings at peak exercise point overwhelmingly toward the respiratory system being the limiting factor, you'll see specific signatures in the data. For instance, the patient might reach their predicted maximal ventilation.
Meaning they're breathing as fast and deep as predicted for their size and age.
Pretty much, yeah. Their lungs and respiratory muscles simply can't move any more air, even though their heart might have capacity left. You might also see evidence of increased dead space ventilation.
Which means wasted ventilation, right? Air going in, but not participating in gas exchange.
Precisely. The ratio of ventilation to perfusion, VQ matching, is poor. Air is going to parts of the lung that aren't getting adequate blood flow. Developing a hypoxemia during exercise, a drop in blood oxygen saturation, is another clear sign the lungs aren't transferring oxygen effectively under increased demand.
Makes sense.
Or you might observe exercise-induced bronchospasm, where the airways actually narrow during exercise, limiting airflow. These are all hallmarks of the breathing apparatus itself hitting its limit.
Right, so lungs are working as hard as they possibly can, maybe even hitting their predicted max, but they just can't keep up with the demand. Now, how does that picture change if the PPE suggests the cardiovascular system is the main culprit behind the dyspnea?
Well, the pattern shifts. You start seeing signs of the heart and circulation struggling to meet the demands. The source points to findings like the heart rate exceeding 85% of the predicted maximum very early in exercise, or maybe reaching maximum heart rate at a very low workload.
So the heart's trying to compensate with rate because it can't pump enough volume.
That's the idea, yeah. An excessive chronotropic response, because the heart is relying too much on rate instead of stroke volume. An early anaerobic threshold is another key marker. This is the point where the body starts producing lactate, because the cardiovascular system isn't delivering enough oxygen to the muscles for purely aerobic metabolism.
Okay, hitting the wall early.
Exactly.
Yeah.
Excessively high blood pressure during exercise, or paradoxically blood pressure that falls as workload increases. Those are significant red flags for cardiac dysfunction. And a crucial metric, as the source highlights, is the O2 pulse.
Right, O2 pulse. Remind us what that is again.
It's calculated as oxygen consumption divided by heart rate, and it's considered a surrogate measure for stroke volume, how much blood the heart pumps with each beat.
Got it.
So the O2 pulse doesn't rise adequately, or even worse, falls during exercise. It strongly suggests the heart isn't pumping enough blood with each beat to match the body's oxygen needs.
Okay.
And finally, of course, seeing ischemic changes on the electrocardiogram during the test is a clear sign of insufficient blood flow to the heart muscle itself, limiting its pumping ability.
That's incredibly powerful, using these distinct physiological patterns to separate limitations that can feel very similar to the patient. But you mentioned CPE's reach goes beyond just the heart and lungs.
Absolutely. The source notes that CPIC can also help pinpoint other, less common but significant drivers of dyspnea. This includes things like a peripheral extraction deficit.
Meaning the muscles aren't pulling oxygen out of the blood effectively?
Exactly. The blood is getting there, maybe, but the muscles themselves aren't efficiently extracting the oxygen. It can also reveal limitations due to metabolic or neuromuscular diseases that affect energy utilization or the function of the muscles, including those involved in breathing or movement.
So it's not just a cardiopulmonary test, it's really a test of the integrated physiological response to stress.
That's the perfect way to put it. It's a comprehensive approach that helps ensure you don't miss less obvious causes when the primary suspects don't fully explain the patient's symptoms.
Sure.
It provides objective data to support or refute clinical suspicion across multiple systems.
Okay, let's unpack this for you listening. Understanding the level of detail and the specific markers used in CPET interpretation is key to grasping how specialists diagnose complex dyspnea. It shows that figuring out breathlessness, especially when multiple conditions are present, isn't just guesswork, right?
Not at all.
It's about using objective physiological data generated under the real-world stress of exercise to definitively identify the primary limitations and disentangle those often intertwined cardiac and pulmonary threads. It's moving from subjective complaint to objective physiological truth. Right? So CPET helps us figure out why someone is breathless. Now, let's shift gears to what happens once we have a clearer picture, or maybe even when we don't, treating dyspnea.
Yeah, the treatment approach. The source lays out the fundamental principle here.
Yeah.
The absolute first goal is always to identify and correct the underlying condition or conditions driving the breathlessness.
Address the root cause.
Address the root cause. Exactly. You have to address the reversible causes first. And because dyspnea is so often multifactorial, this frequently means a combination of interventions targeting different issues simultaneously. You can't just treat one thing if others are contributing significantly.
Okay. Fix the root cause whenever possible. But what if, despite optimal treatment of the underlying diseases, the patient still experiences significant breathlessness? What then?
That's where the secondary goal comes in. If full or complete relief of dyspnea isn't achievable by treating the underlying pathophysiology, and sometimes it just isn't, then the focus shifts to symptom management.
Right.
It becomes about lessening the intensity of the breathlessness itself and improving the patient's quality of life, making it more bearable.
And the source introduces a specific term coined by an international expert group for this persistent, disabling breathlessness, right?
Yes, this is the concept of chronic breathlessness syndrome, or CBS. It was defined back in 2017 through a consensus process.
And the definition is key here.
Yeah, the precise definition is the experience of breathlessness that persists despite optimal treatment of the underlying pathophysiology and results in disability for the patient. It emphasizes both persistence despite optimal treatment and the resulting disability.
Why is giving the specific label important? Why call it CBS?
Well, it's crucial for formal recognition, really. By defining CBS, it elevates persistent refractory breathlessness from just being a symptom of another disease to a syndrome in its own right.
Oh, okay.
This recognition helps healthcare professionals focus specifically on symptom management strategies when a complete cure of the underlying cause isn't possible. It legitimizes the symptom itself as a target for intervention, which is important.
The source mentioned something interesting, that despite our increased understanding of the physiological mechanisms behind dyspnea, translating that into new, effective treatments specifically for the symptom of breathlessness has seen limited progress.
That's a rather sober point the source makes, yes. It underscores that knowing how a symptom is generated hasn't automatically led to breakthroughs in therapies to relieve it directly. It's a bit frustrating, really.
Yeah.
This sets the stage for discussing the current landscape of available treatments, acknowledging that while some are effective for underlying conditions, options for direct symptom relief of breathlessness remain an area needing much more research.
Okay, let's walk through the specific treatment modalities discussed in the source. First up, perhaps the most obvious one, supplemental oxygen. What are the guidelines for its use? Is it for anyone feeling breathless?
No, definitely not for everyone. The source provides clear criteria. Supplemental oxygen is indicated if the patient's resting oxygen saturation is 88% or lower, or if their saturation drops to that level with activity or during sleep.
So it's tied to objective hypoxemia.
Exactly. It's not for everyone who feels breathless. It's specifically for those who have objective evidence of hypoxemia, low blood oxygen levels.
And is oxygen just about making someone feel more comfortable when they're hypoxemic, or does it offer more than just symptom relief?
In specific situations, it's much, much more than just comfort. The source uses the critical example of patients with severe COPD and chronic hypoxemia. In this population, supplemental oxygen therapy has been definitively shown to improve mortality.
Wow, so it actually extends life.
It extends life. So when indicated by low oxygen levels in these patients, it's a life-extending treatment, not just a palliative measure. That's a really key distinction to make.
That's a really vital point. What about pulmonary rehabilitation? What does that entail, and what are its benefits? Sounds like exercise.
It often involves exercise, yes, but it's broader than that. Pulmonary rehabilitation programs generally involve supervised exercise training, patient education, and behavioral interventions. The source specifically mentions examples of community-based programs like yoga and tai chi as modalities that fall under this umbrella.
Interesting. And the benefits?
The documented benefits are significant. These programs consistently improve dyspnea severity, they increase exercise capacity, and they actually reduce hospitalization rates in patients with chronic respiratory conditions.
So it's about training the body to function better within its limitations and helping patients develop coping strategies. It sounds quite holistic.
Exactly. It addresses both the physical deconditioning that often accompanies chronic breathlessness and also the anxiety and fear that can worsen the symptom. It's a holistic approach focused on function and improving quality of life. Highly effective.
The source also discusses the controversial but sometimes used role of opioids in managing dyspnea. How are they thought to work for breathlessness?
Yeah, controversial is the right word. Opioids, even at low doses, have been shown to reduce the subjective intensity of breathlessness, particularly that sensation of air hunger.
Air hunger, right.
The proposed mechanisms involve a degree of suppression of the central respiratory drive in the brainstem and influencing the processing of respiratory sensations in higher cortical centers. They essentially blunt the brain's perception of the uncomfortable breathing signal.
And the source includes a crucial caveat regarding their use. A big warning label, basically.
An absolutely essential caveat, yes.
Mm-hmm.
The source emphasizes that the use of opioids for dyspnea must be very carefully considered on an individual risk-benefit basis. The primary risk, particularly at higher doses, is respiratory depression.
Slowing down breathing too much.
Potentially suppressing breathing too much, which can be life-threatening, especially in patients with already compromised respiratory function. So it requires careful patient selection, very cautious dosing, and close monitoring. It's not a first-line therapy for most.
What about medications typically used for anxiety, like anxiolytics? Does the source mention those?
It notes that these agents are currently under study for their potential role in dyspnea management. It acknowledges that anxiety is often intertwined with the experience of breathlessness, which makes sense, but they aren't presented as a standard, proven therapy for dyspnea itself just yet. More research needed there.
And are there novel investigational agents targeting dyspnea, things in the pipeline?
Yes, research is ongoing, exploring different pathways. The source gives inhaled furosemide as an example of an agent that has been studied.
Furosemide, like the diuretic, inhaled.
Exactly, inhaled furosemide. The proposed mechanism for its potential effect on dyspnea is fascinating. It's thought to alter affect-sensory information originating in the airways or lungs, essentially modulating the signal that gets sent to the brain to perceive breathlessness.
So targeting the sensory input directly.
That's the idea. This highlights efforts to target the sensory pathways of dyspnea directly, rather than just focusing on the underlying mechanics of breathing or circulation. It's a different approach.
This really shows how managing dyspnea is such a multifaceted challenge, doesn't it? It involves optimizing underlying conditions, leveraging therapies like pulmonary rehab and oxygen when indicated, cautiously using symptom-specific agents like opioids sometimes, and actively pursuing new therapeutic avenues.
Absolutely.
For you listening, understanding this range of approaches from the established to the experimental provides a deep look into the current strategies used to improve life for those struggling with persistent breathlessness, especially when the underlying cause isn't fully reversible. It's a critical area where both disease management and symptom palliation are just vital. All right, let's shift our focus now to the other major symptom. Chapter 38 untacks the cough. We all cough, right? It seems simple, maybe just annoying, but the source starts by elevating its status beyond just a nuisance.
It absolutely does. The source emphasizes that cough is not just an annoyance. It's a truly vital protective reflex mechanism for our airways and lungs. Think of it as the body's primary way to prevent catastrophe down there.
A protective mechanism?
Yeah.
How so?
It explains why it's vital. Without an effective cough, we would retain secretions in our airways and lungs and fail to clear aspirated material, anything that goes down the wrong pipe, like food, liquids, saliva.
Right.
Retained secretions or aspiration significantly increase the risk of serious complications, like infection, pneumonia, atelectasis, which is collapse of lung tissue, and overall respiratory compromise. Cough keeps the pipes clear.
So it's our built-in security system for the airway. But like any powerful system, too much can cause problems. The source balances the protective role with the downsides of excessive cough.
That's a crucial distinction, yeah. While necessary, chronic or excessive coughing can be incredibly debilitating and even harmful in itself. The source details the negative consequences. It's exhausting for the patient, physically tiring. It can lead to complications like emesis, vomiting from coughing so hard, syncope, which is fainting due to transient reduction in blood flow to the brain during forceful coughing.
Wow, fainting from a cough.
It happens, and severe muscular pain in the chest or abdomen. More severely, the intense pressures generated can even cause rib fractures.
Rib fracture?
Yes. Beyond these direct physical effects, chronic cough can aggravate existing conditions, making low back pain worse, worsening abdominal or inguinal hernias, and contributing to urinary incontinence, particularly in women. And, as the source rightly stresses, its impact as a major impediment to social interactions.
Yeah, the social isolation.
Leading to isolation and embarrassment is a huge quality of life issue. It really impacts people's lives.
That paints a vivid picture of the double-edged nature of cough. The source then notes that cough often serves as a critical diagnostic clue, signaling the presence of respiratory disease.
Yes. While an acute cough accompanying a cold or flu is expected, the source focuses on the cough that persists without other obvious accompanying symptoms. This chronic cough is one of the most common reasons patients seek medical attention. It's a signal that something isn't quite right in the respiratory system or, as we'll see, sometimes elsewhere.
Now, let's really delve into the physiological engine of the cough, just as the source does. It's described as a complex reflex arc. What initiates it? What are the stimuli that kick it off?
The source describes cough being triggered by both chemical and mechanical stimuli. Chemical irritants could be things like capsaicin, stuff in chili peppers, or irritant gases, smoke. Mechanical stimuli are more about physical presence in the airway, think mucus, inhaled dust particles, or aspirated material touching the lining.
And how does the body sense these stimuli in the airway? What are the detectors?
That's the role of specific sensory receptors, often specialized nerve endings embedded in the airway lining. The source names key players. Cationic channels like transient receptor potential channels, TRP channels you might hear them called.
That's higher P channels, okay.
These are activated by a range of stimuli, including mechanical ones, chemical irritants, and temperature changes. And also adenosine triphosphate activated ion channels, specifically mentioning P2X3 receptors. Yeah, these seem particularly sensitive to chemical irritants and potentially mechanical stress as well. These receptors are the initial detectors, the sentinels.
So these specialized nerve endings pick up the signal. How does that signal travel to the brain to initiate the reflex? What's the pathway?
The signals travel along afferent nerve fibers towards the central nervous system. The source distinguishes between two main types. A fibers, which are typically myelinated and conduct faster, carrying mechanosensory information, that feeling of something physically being there.
Okay, the touch sensation.
Sort of, yeah. And then C fibers, which are unmyelinated, conducting slower, and primarily carry chemosensory information, responding to chemical irritants.
Where exactly are these crucial sensory nerve endings located throughout the body? Is it just limited to the main airways, the trachea and bronchi?
This is a critical point about the widespread distribution of the cough reflex's sensory arm, and it explains some less obvious cough triggers. While they are densely innervated in the pharynx, the larynx, and extending down the airways as far as the terminal bronchioles, and even into the lung parenchyma itself.
So deep into the lungs.
Deep into the lungs, yes. But crucially, they are also found in extra-respiratory sites.
Outside the respiratory system.
Exactly. The source explicitly calls out the external auditory canal, the ear canal.
An ear canal? Really?
Yes, which is supplied by the auricular branch of the vagus nerve, often called Arnold's nerve. This connection explains why simply cleaning your ear with a cotton swab can sometimes trigger a cough in some people.
I've heard of that. Arnold's nerve reflex.
That's the one. Another important extra-respiratory site mentioned is the esophagus, which provides a direct link explaining how conditions like gastroesophageal reflux can trigger cough.
That's fascinating. It really highlights how complex and widely distributed the system is. So the signals travel along the A and C fibers from all these locations, airways, ear, esophagus. Where do they converge in the brain?
They travel via the vagus nerve and the superior laryngeal nerve up to the brainstem, specifically targeting a region called the nucleus tractus solitarius, or NTS.
NTS, okay.
Within the NTS and surrounding brainstem areas, integrated neural networks process this incoming sensory information. The source explains that this central processing is where the raw sensory input is translated into the conscious perception we recognize as the urge to cough. It's the brain interpreting the signals and telling you, hey, something needs to be expelled.
So the brainstem gets the message, processes it, and you feel the urge. Then comes the dramatic physical act, the efferent limb of the reflex. How is that muscular action coordinated? Is it just automatic?
It's a highly precise and orchestrated series of involuntary muscular contractions and relaxations. Pretty much automatic, yes. Though the source notes there's also potential input from cortical pathways, higher up in the brain, allowing us to voluntarily initiate a cough or suppress an urge to cough, at least to some extent.
All right, you can make yourself cough or try to hold one back. Let's break down the mechanical steps of a single cough. What happens first?
The very initial step is vocal cord adduction. The vocal cords snap shut tightly, momentarily closing off the upper airway at the level of the larynx, like closing a valve.
Valve closed. Then what?
Right after the vocal cords close, there's a powerful, forceful contraction of the expiratory muscles. This primarily involves the abdominal muscles and the internal intercostal muscles between the ribs.
Okay, squeezing the chest and belly.
Exactly. Because the airway is closed at the top by the vocal cords, this muscular contraction compresses the air trapped in the lungs and airways, generating extremely high positive intrathoracic pressures. The source notes these pressures can reach up to 300 mmHgs.
300 millimeters of mercury. That's immense pressure inside the chest. What happens then to create the expulsion, the blast?
Right. With that high pressure built up behind the closed vocal cords, there's a sudden explosive release. The laryngeal muscles rapidly relax and the vocal cords fly open. This sudden release of pressure drives an incredibly rapid burst of expiratory airflow out of the lungs.
Like uncorking a champagne bottle.
Kind of, yeah. A very forceful uncorking. The source points out that the velocity of this airflow actually exceeds the normal limits of maximal expiratory flow you'd see during, say, forced breathing for a lung function test. It appears as sharp spikes outside the typical envelope on a flow volume curve, which is illustrated nicely in Figure 38.1 of the source.
That extreme velocity is key to clearing the airways, right? How does the body maximize that speed? Is it just the pressure release?
The pressure release is key, but there's more. This is where the physics and mechanics come together elegantly. During the forceful exhalation of the cough, there's simultaneous contraction of bronchial smooth muscle and dynamic compression of the airways, particularly the larger ones.
So the airways themselves narrow?
They narrow actively, yes. This narrows the lumen, the inside diameter, of the airways. By forcing the same volume of air through a narrower tube, the body maximizes the velocity of the expiratory airflow.
Ah, like putting your thumb over a garden hose?
Exactly like that. And here's the physics the source highlights. The kinetic energy available to dislodge mucus or foreign material from the airway walls is directly proportional to the square of the velocity of expiratory airflow.
Square of the velocity. So a little faster means much more force.
Much more force. Small increases in velocity lead to disproportionately large increases in the shearing force available to sweep material out. Higher velocity equals much, much more effective clearance.
That's a brilliant piece of biological engineering. And the source mentions coughing in a series helps optimize clearance, not just one big blast.
Yes. Taking a deep breath before the cough helps optimize the starting volume of air, which allows the expiratory muscles to generate maximal force. Then coughing often occurs in a series of repetitive expulsions.
Right.
The source explains that performing these coughs at successively lower lung volumes helps sweep the point of maximal expiratory velocity progressively further down into the lung periphery. You start clearing from the larger airways higher up, and with subsequent coughs at lower lung volumes, the point where the airways compress dynamically and velocity peaks shifts downwards, helping to kind of milk secretions from smaller, more peripheral airways towards the center where they can be expelled.
Okay, let's unpack this. Understanding this incredibly detailed, multi-step reflex mechanism from the detection of stimuli by specific receptors and nerve fibers, their widespread distribution, including those surprising extra respiratory sites like the ear, central processing into the urge, and the precisely coordinated muscular actions involving vocal cords, muscles, and airway narrowing is fundamental.
It really is.
It explains why different things trigger cough, why it can be so powerful, and, as we'll discuss next, why its disruption can have major consequences. It's the intricate biological engine behind that everyday, sometimes annoying action. So we've explored the powerful protective mechanism of cough. But that protection's compromised if the cough is weak or ineffective. The source delves into what happens when the system fails impaired cough.
That's a critical point. The source states clearly that weak or ineffective cough directly compromises the ability to clear lower respiratory tract secretions and aspirated material. The protection is lost.
And the consequences of that impaired clearance are serious, presumably.
Absolutely. Failure to clear secretions predisposes patients to more serious pulmonary infections, like pneumonia, and their potential complications, such as respiratory failure or sepsis. It leaves the lungs vulnerable to infection and collapse.
The source provides a really useful categorization of the causes of impaired cough, breaking it down by the part of the system that's failing.
Yes, It helps frame the potential problems by thinking about different components of that complex reflex we just discussed. The source lists problems with the engine, the muscles, and structures that generate the force for the cough.
The power source.
Exactly. This includes weakness or paralysis of the key expiratory muscles, the abdominal and intercostals, perhaps due to neurological disease like spinal cord injury or muscle disorders like muscular dystrophy. Pain in the chest wall or abdomen, for example, after surgery or significant trauma, can also severely inhibit the ability to cough forcefully because it just hurts too much.
Right.
And severe chest wall deformities, like severe kyphoscoliosis, physically restrict the lung and chest wall movement needed for a strong cough.
So the machinery to generate the pressure and airflow isn't up to the task. What about issues with the valve, the glottis?
That refers to problems with the glottis, the vocal cords. If there's impaired glottic closure, if the valve doesn't close tightly, you can't build up that high intrathoracic pressure behind the closed airway before the explosive release.
So the pressure just leaks out.
Essentially, yeah. This significantly weakens the cough velocity and effectiveness. Also, the presence of a tracheostomy tube bypasses the larynx and vocal cords entirely, disrupting this crucial pressure-building step and impairing effective cough clearance from the lower airways.
And problems with the control center in the brain. Central issues.
That points to issues with the central processing of the cough reflex in the brainstem. Conditions causing central respiratory depression, such as certain neurological diseases, brain injury, or even the effects of general anesthesia or strong sedation, can blunt the urge to cough or weaken the strength of the efferent signal, making the reflex sluggish or weak.
The source also mentions problems with the cargo and the moving floor. What does that mean?
The cargo refers to the material being coughed up the secretions themselves. If these are abnormally viscous or sticky, like the thick, tenacious mucus seen in cystic fibrosis, even a forceful cough generated by strong muscles can struggle to dislodge and move them effectively.
So the stuff is just too hard to move.
Right. And the moving floor refers to the cilia, the tiny hair-like projections that line the airways. They constantly beat in a coordinated way to move mucus upwards towards the throat, like a conveyor belt, where it can be swallowed or coughed up easily. This is mucociliary clearance. Ciliary dysfunction, such as in the genetic condition primary ciliary dyskinesia, means this conveyor belt isn't working properly. Secretions just sit there in the airways despite cough effort, because the underlying clearance mechanism is broken.
And finally, problems with the pipes themselves, the structure of the airways.
Yes. Structural abnormalities can significantly impact cough effectiveness. The source mentions tracheomalacia or bronchomalacia, conditions where the trachea or bronchi are abnormally soft and floppy and can collapse excessively during the forceful exhalation of a cough.
So the pipe collapses under pressure.
Exactly. This collapse obstructs airflow, preventing effective clearance from below the point of collapse. Other structural issues like bronchiectasis, where airways are chronically dilated, damaged, and often filled with secretions, or tracheal or bronchial stenoses, which are fixed narrowings, can also impede the movement of air and secretions during cough.
Given this range of potential mechanical and neurological issues, how do clinicians assess how effective someone's cough actually is? Is it just listening?
Clinically, it's often assessed qualitatively. How does it sound? How strong does it appear? Does the patient seem to be successfully moving secretions? But the source notes that objective surrogates can be used to get a more quantitative measure.
Like what?
These include measuring peak expiratory flow during a forced cough maneuver, or measuring maximal expiratory pressure generated at the mouth against a closed valve, MEP. These numbers can give a more precise indication of the force and flow the patient can generate with their cough effort.
Are there ways to help improve cough efficacy when these underlying problems exist? Can you boost a weak cough?
Absolutely. A range of assistive devices and techniques have been developed, from simple to complex. The source mentions basic physical maneuvers, like teaching a patient with postoperative abdominal pain to splint their incision with a pillow while coughing. This provides support and allows them to generate more force with less pain.
Simple but effective.
Yeah. On the more complex end are mechanical cough assist devices, sometimes called insufflator-exsufflators. These devices can be used via a face mask or sometimes through a tracheal tube. They work by applying a cycle of positive pressure to inflate the lungs deeply, followed immediately by a rapid shift in negative pressure to suck the air out forcefully.
So it simulates a cough mechanically.
It essentially provides an artificial cough, mimicking the pressure changes and high flows to help clear secretions, especially in patients with weak respiratory muscles or impaired glottic function.
So providing external assistance to that compromised system.
Exactly. And the source reinforces a crucial point here. Even if a patient can generate normal expiratory velocities during a cough maneuver, the cough can still fail to clear secretions effectively if the fundamental problem lies with the secretions themselves being too sick, the cargo, or with non-functional cilia, the moving floor, or significant structural abnormalities in the airways that impede flow or cause collapse, the pipes. Velocity alone isn't enough if these other factors are compromised.
This highlights that cough isn't just about making noise. Its effectiveness in clearing material is paramount. And understanding the different points where that complex reflex can fail the engine, the valve, the control, the cargo, the floor, the pipes, is essential for diagnosing impaired cough and knowing where to target interventions. It's a vital protective function that many conditions can undermine, leading to really significant clinical consequences. Okay, let's transition now to one of the most common and often frustrating clinical scenarios. Assessing chronic cough, specifically when it's the patient's dominant symptom. The source defines chronic cough as lasting more than 8 weeks.
Yes, when that cough hangs around for over 2 months, especially without a clear acute infection causing it, it triggers a systematic diagnostic process. Time to investigate properly.
And the source makes an interesting point right off the bat that might surprise people who've tried to, self-diagnose based on how their cough sounds, that the characteristics of the cough itself, its sound, timing, pattern, are infrequently helpful in determining the underlying cause.
That's a key takeaway the source provides, and it really goes against common intuition, doesn't it? People often describe their cough in great detail. It's a dry, hacking cough, or it's wet and rattling. It happens more at night.
Right.
But the source states that details about the sound, the resonance, specific timing during the day, or whether it occurs in paroxysms, are generally not reliable clues to the specific etiology.
Yeah.
There are some exceptions, maybe specific triggers like allergic exposures or exercise in cold air, which might point towards asthma. But generally, relying just on the sound or pattern isn't the way to diagnose the cause of chronic cough. You can't diagnose it by ear, usually.
So if the characteristics aren't the main clue, what factors do commonly influence cough, regardless of the specific cause?
The source notes general circumstances that frequently worsen cough, irrespective of the underlying reason. These include assuming a supine position lying down, especially when first going to bed at night.
The classic coughing when I lie down.
Exactly. Talking can trigger it. And the increased breathing rate and depth that occurs with exercise, hyperpnea, often provokes cough. Conversely, cough frequently improves or even resolves completely during sleep. These patterns are common across various causes and don't typically pinpoint a single diagnosis.
Okay, so we can't rely just on the sound or pattern. What are the essential historical questions a clinician should be asking when evaluating chronic cough? What is important in the history?
The source suggests focusing on the circumstances surrounding the onset of the cough. Was it after a specific illness, a viral infection perhaps? Did it start after beginning a new medication? Was there new environmental exposure? Also, what factors the patient has noticed make the cough better or worse?
Okay.
And critically, does the cough produce sputum? And if so, what does it look like? Asking about sputum production is highlighted as indispensable because a productive cough immediately points towards processes involving mucus hypersecretion, which significantly narrows the list of potential diagnoses compared to a dry, non-productive cough. That's a key branching point.
Makes sense. What about the physical examination? What clues are sought during the physical exam?
The physical examination is also a crucial step, and the source details what the clinician is specifically looking for. They'll perform a thorough cardiopulmonary exam, listening carefully to the chest for signs like wheezing or crackles.
Standard stuff,
But important. But they also extend the exam to other areas because of that widespread distribution of the cough reflex we talked about and the potential for systemic causes. So this includes examining the external auditory canals and tympanic membranes. We're calling that Arnold's nerve connection.
Checking the ears for cough, yeah.
Checking the ears, checking the nasal passages for signs of rhinitis, polyps, or excess secretions dripping down. They might check the fingernails for clubbing, which can suggest chronic cardiopulmonary disease.
It really reinforces the interconnectedness we discussed earlier, and the general examination is important too.
Yes, the source emphasizes the importance of a thorough general physical examination. Why? because cough can be the presenting symptom or a significant feature of systemic diseases that affect multiple organs, things like sarcoidosis or certain types of vasculitis. The general exam might reveal other clues pointing towards these conditions outside the chest itself.
Now, the source mentions a test that is considered virtually mandatory in the workup of chronic cough, an essential first step.
Yes, the chest radiograph. The chest X-ray. The source states unequivocally that evaluation of chronic cough virtually always merits obtaining a chest radiograph. It is an indispensable initial screening tool. You basically have to get one.
Why is a chest X-ray so essential, especially if the physical exam seems completely normal?
Because, as the source explains, a significant list of serious underlying diseases that can cause persistent cough can present with a totally normal physical examination, but will show abnormalities on a chest X-ray. Examples given include certain lung cancers, especially in older patients or smokers, sarcoidosis, Hodgkin's lymphoma, particularly in younger adults, or pulmonary tuberculosis, which is a critical consideration globally. Missing these potentially serious conditions is unacceptable, and the X-ray is the first line of defense against that.
And if the X-ray is abnormal,
then the subsequent diagnostic workup focuses specifically on evaluating that detected abnormality. The X-ray guides the next steps.
it's a critical step to rule out major structural or infectious diseases. What if the cough is productive, the patient is bringing up sputum? What do you do with that?
For chronic productive cough, examining the expectorated sputum is definitely warranted. Figuring out the cause of that mucus hypersecretion is a crucial clue to the underlying disease process. You need to know what's in it.
How is the sputum analyzed? What tests are done?
Well, if the sputum looks purulent, meaning thick, colored, looking infected, it should be sent for routine bacterial culture to identify potential bacterial pneumonia or chronic bronchitis. In appropriate clinical settings, especially in areas where TB is prevalent or if suspicion is high based on other factors, mycobacterial culture for TB is also necessary.
Okay. What about sputum that isn't obviously infected, just maybe excessive mucus?
The source also mentions the utility of cytologic examination of mucoid sputum that's not necessarily infected but seems abnormal or excessive. Cytology can assess for malignant cells, look for evidence of oropharyngeal aspiration, like food particles or certain cell types, and importantly can help distinguish between neutrophilic bronchitis, inflammation dominated by neutrophils, and eosinophilic bronchitis, inflammation dominated by eosinophils, which have different treatment implications.
And finally, the source briefly touches on coughing up blood, or hemoptysis. What's the takeaway there?
Yes. It notes that expectoration of blood, whether it's just streaks mixed in with sputum or frank blood, is a symptom that requires a special, distinct approach to assessment and management. It's an alarm symptom.
So a separate workup pathway.
Essentially, yes.
Yeah.
It refers the listener to the subsequent chapter in the source for a detailed dive into hemoptysis, emphasizing it's a symptom that cannot be ignored and warrants its own specific evaluation within the chronic cough workup if present.
This section gives us that systematic roadmap for evaluating chronic cough. For you listening, understanding this process, starting with the history, focusing on onset, triggers, sputum, the physical exam, including ears and nose, the absolutely indispensable chest x-ray, and then targeted sputum analysis if productive shows you the logical steps clinicians take. It highlights why certain questions are key, why the exam goes beyond just the chest, and why that x-ray is non-negotiable. It's about systematically ruling out the serious stuff and narrowing down the possibilities.
All right, let's hone in on the scenario that clinicians face most frequently after the initial workup. Chronic cough, where the chest radiograph comes back normal, the x-ray is clear. This is where the true detective work often begins, right?
Exactly. This is very common. As the source points out, even with a clear chest x-ray, the list of potential causes for persistent cough without other significant symptoms is still long. But the search becomes more focused, typically starting with what the source identifies as the most common etiologies in this specific setting. And the source introduces the idea of the big four, or perhaps big five, common causes when the initial screen is negative, the usual suspects.
Yes, there's a widely held concept, which the source discusses, that 4 conditions are most frequently responsible for chronic cough in patients with a normal chest x-ray. These might occur alone or sometimes in combination, although the source includes a pragmatic note based on clinical experience that sticking rigidly to just these 4, or assuming they always occur in isolation or specific combinations, isn't always borne out in practice. It can be more complex.
Okay, but what are these common ones?
The 4 usually listed are ACE inhibitors, the medication side effect, gastroesophageal reflux, GERD, rhinosinusitis with excessive nasopharyngeal drainage, often now called upper airway cough syndrome or a UACS, and cough variant asthma. The source also discusses eosinophilic bronchitis in this context, which is another important cause of chronic cough with a normal chest x-ray, often considered alongside asthma because of the eosinophilic inflammation. So maybe 5 key players to consider first.
Let's break down these common culprits, starting with ACE inhibitor cough. That's a direct drug side effect, right? We know the drug causes it.
Precisely. Angiotensin-converting enzyme, ACE. Inhibitors medications widely used to treat hypertension and heart failure, things like lisinopril, ramipril, or a common and very specific cause of chronic cough. It occurs in a significant percentage of patients taking these drugs. The source says maybe 5% up to as high as 30%.
That's a big range.
It is. And a notable characteristic the source highlights is that this cough is not dose-dependent. Taking a higher or lower dose doesn't necessarily make you more or less likely to get it.
What's the physiological mechanism behind this drug-induced cough? Why do ACE inhibitors do this?
The source explains the suspected mechanism involves the drug's effect on the metabolism of bradykinin and other tachykinins, like substance P-ACE, the enzyme that the drug inhibits, normally breaks down these substances in the body. When ACE is inhibited by the medication, bradykinin and these other tachykinins can accumulate. It's suspected that this accumulation sensitizes sensory nerve endings in the airways, lowering the threshold and making the cough reflex much more easily triggered. Makes them hypersensitive.
So the drug makes the cough sensors more sensitive.
Yeah.
How is this diagnosed then, if someone's on an ACE inhibitor and coughing?
The diagnostic approach is straightforward, but absolutely critical. The source strongly recommends a trial period off the ACE inhibitor for any patient presenting with chronic, unexplained cough who is taking this class of medication.
Any patient, even if the cough started long after the drug.
Yes, and importantly, this trial period should be done regardless of when the cough started relative to starting a drug. Sometimes the cough can develop months or even years into therapy. It's not always immediate, so you always have to consider it.
And are there safe alternative medications for their underlying condition, like hypertension, if the ACE inhibitor is stopped?
Yes, absolutely. The source mentions that angiotensin receptor blockers, ARBs, drugs like losartan or valsartan, are a class of medications with similar cardiovascular benefits, but they do not cause this type of cough. They work differently. So they are a suitable alternative if the ACE inhibitor turns out to be the culprit.
How long should this trial period off the ACE inhibitor last before you can reasonably conclude whether it was the cause or not?
The source provides a useful time frame. Failure to see a significant decrease in cough after about 1 month off the medication strongly argues against the ACE inhibitor being the cause. If it is the cause, improvement often starts within a few weeks, but can take up to a month or sometimes slightly longer to fully resolve.
That's a clear guideline for clinicians. Let's move to the next common cause, postnasal drainage, or as the source also terms it, upper airway cough syndrome, UACS.
Yes. The traditional thinking here is that excessive secretions dripping down the back of the throat from the nose and sinuses stimulate the cough receptors located in the hypopharynx, or potentially microaspirate, into the larynx and trachea, triggering cough. That's the postnasal drip idea. The term upper airway cough syndrome, UACS, is now often preferred because it encompasses the idea that chronic inflammation in the nose and sinuses can cause cough even without clearly visible postnasal drainage. It might be the inflammation itself sensitizing the upper airway cough receptors.
So it's not always about the drip you can see or feel.
Not necessarily, no. What kind of historical clues might point towards UACS then?
Well, patients might report that classic sensation of something dripping in the back of their throat or needing to clear their throat frequently. They might also have associated symptoms like sneezing and rhinorrhea, runny or stuffy nose. And what might a clinician find on physical examination? What do you look for?
Looking inside the nose with a speculum might reveal excess mucoid or purulent secretions, maybe inflamed and swollen nasal mucosa or sometimes nasal polyps. Examining the back of the throat, the posterior pharyngeal wall, might show secretions dripping down or a characteristic cobblestoned appearance of the mucosa, which indicates chronic irritation.
It sounds like combining the history and physical might clinch the diagnosis, but the source notes a significant challenge here too, similar to ACE inhibitors.
A major challenge is the subjectivity and lack of a gold standard test. There's no objective way to quantitate how much postnasal drainage someone has or how inflamed their upper airway is just from looking. So the diagnosis often relies heavily on the patient's subjective report of symptoms and the clinician's interpretation of the exam findings.
Right.
Furthermore, and this is a critical point the source makes again, Many people have signs or symptoms of chronic postnasal drainage or rhinitis, but do not experience chronic cough.
So the link isn't always direct.
Exactly. This observation complicates definitively linking the drainage or inflammation to the cough in every single case. It means the presence of drainage isn't absolute proof, it's the cause of the cough. Correlation isn't causation here.
That's a really important clinical nuance. Let's tackle the next common cause. Gastroesophageal reflux, or GERD, another tricky one.
Another frequently suspected but sometimes challenging to prove cause. Yes.
Yeah.
GERD-associated cough. The main proposed mechanism is a reflex pathway.
Okay.
Reflux of gastric contents, stomach acid, maybe bile, pepsin into the lower esophagus is thought to trigger cough via vaguely mediated reflexes originating from sensitized nerve endings in the esophageal lining. The esophagus gets irritated and sends a signal that results in cough.
And what about reflux going higher up?
Yes, the source also mentions laryngopharyngeal reflux, LPR, where stomach contents reach all the way up to the larynx or pharynx. This could potentially cause direct chemical irritation or even microaspiration leading to cough, though the source notes that overt chemical bronchitis or pneumonitis from aspiration is actually rare among patients presenting primarily with chronic cough.
What symptoms might suggest GERD as the cause? The classic ones.
Patients may report classic GERD symptoms like retrosternal burning or heartburn, often worse after meals or when lying down. Frequent belching, maybe hoarseness, especially in the morning, or throat pain could also be clues.
But just like with UACS, there's a diagnostic challenge regarding symptoms, isn't there?
Absolutely, and this is crucial. The source states that reflux, even significant reflux, can occur with minimal or no typical symptoms whatsoever. This is often called silent reflux.
Silent reflux.
Yeah. This makes relying on patient history alone very difficult for diagnosing GERD-related cough. The patient might have no heartburn at all, but still have reflux triggering their cough.
Are there physical findings related to GERD cough? Anything to see?
A clinician performing laryngoscopy, looking at the voice box with a scope, might see inflammation of the vocal cords, sometimes called glottic inflammation or posterior laryngitis, which can be a sign of recurrent reflux reaching that area. However, the source immediately qualifies this by stating it's a nonspecific finding.
Meaning other things can cause it.
Exactly. Many other things can cause glottic inflammation, so seeing it doesn't prove GERD is the cause of the cough.
Since symptoms and physical exam findings can be subtle, absent, or nonspecific, are there objective tests to confirm reflux? Can you measure it?
Yes, there are more invasive but objective ways to assess reflux. The gold standard traditionally is 24-hour esophageal pH monitoring. This involves placing a thin catheter with a pH probe through the nose down into the esophagus, or sometimes endoscopically attaching a wireless pH capsule to the esophageal wall. These devices record how often and for how long acid refluxes into the esophagus over a full day.
Okay, measuring the acid exposure.
Right. And newer techniques include esophageal manometry, which measures pressures and muscle function in the esophagus, and impedance pH monitoring, which can detect non-acid reflux events, like a reflux of weakly acidic or alkaline stomach contents, as these might also trigger cough via different mechanisms.
But even with these objective measurements, definitively linking the reflux events to the cough episodes can still be tricky.
That's correct. The source notes that the precise interpretation of these test results, particularly in establishing a definitive causal link between observed reflux events and the patient's specific cough episodes, often requiring symptom correlation analysis, remains an area of some debate among experts. It's not always clear-cut.
Right.
And echoing the point about UACS, the source adds another important counterpoint. Many people who have significant symptomatic reflux, even proven on testing, do not experience chronic cough. This further complicates assuming causality based solely on finding reflux on monitoring. The reflux might be there, but is it causing the cough?
So it's often a diagnosis of suspicion, maybe supported by testing, but not always definitively proven. A therapeutic trial might be needed.
Often, yes. A trial of aggressive anti-reflux therapy is frequently used diagnostically.
Okay. Let's move to cough variant asthma, CVA. What's the definition there?
Cough variant asthma is a specific phenotype or type of asthma where chronic cough is the sole or predominant symptom. They don't necessarily wheeze or feel short of breath, they just cough. The source notes it's relatively common in children presenting with chronic cough, but perhaps a bit less so in adults compared to the other causes.
How is CVA diagnosed or excluded with certainty? How do you nail this one down?
Unlike UACS or GERD, the diagnosis here can often be established objectively. It's done by demonstrating either reversible airflow obstruction on spirometry, meaning their lung function tests show airway narrowing, that improves significantly after inhaling a bronchodilator medicine.
The standard asthma test.
Pretty much. Or, if spirometry is normal, by a positive bronchoprovocation challenge test. In this test, the patient inhales increasing doses of a substance like methacholine, which constricts airways in susceptible individuals, like those with asthma. A significant drop in lung function or triggering of their typical cough with low doses confirms bronchial hyperresponsiveness, which is the hallmark of asthma.
And can you rule it out definitively, too?
Yes. Conversely, a negative bronchoprovocation challenge test, meaning no significant reaction even at higher doses, reliably excludes asthma, including CVA, as the cause of the chronic cough. It's a very useful rule-out test.
Are there any simpler tools that can help support the diagnosis, maybe something done at home?
Yes. For a cooperative patient, home expiratory peak slow monitoring can be helpful. The patient uses a simple handheld device to measure their maximal speed of exhalation several times a day. Significant variability in these readings from day to day or after exposure to triggers can be characteristic of asthma and serve as a cost-effective way to support or discount the diagnosis, though it's less definitive than formal spirometry or challenge testing in the lab.
And finally, eosinophilic bronchitis, EB. How does this fit into the picture of chronic cough with a normal X-ray?
Eosinophilic bronchitis is an important distinct cause of chronic cough that also occurs with a normal chest radiograph. The key diagnostic feature is the presence of sputum eosinophilia.
Eosinophils in the sputum, like in asthma.
Yes, eosinophils are present, often meaning more than 3% of the inflammatory cells in the induced sputum sample are eosinophils. However, crucially, this occurs without the objective evidence of airflow obstruction or bronchial hyperresponsiveness that you see in asthma. So it's eosinophilic inflammation causing cough, but without the variable airflow limitation or twitchy airways of asthma. That distinction is key.
And how is eosinophilic bronchitis treated?
The source states that eosinophilic bronchitis is successfully treated with inhaled glucocorticoids, similar to asthma. This highlights that the underlying eosinophilic inflammation is steroid responsive, even if the physiology isn't identical to asthma.
Is there a potential novel diagnostic or predictive marker for this and maybe asthma-related cough? Something non-invasive?
Yes, the source mentions the measurement of the concentration of nitric oxide in exhaled breath, often called FeNO, fraction of exhaled nitric oxide.
FeNO testing.
Right. This non-invasive test can detect eosinophilic airway inflammation, which is present in both asthma and eosinophilic bronchitis. Elevated FeNO levels may also help predict which patients with chronic cough, even if the specific cause isn't definitively known yet, might respond favorably to a trial of inhaled steroids. It can help guide therapy.
This deep dive into the common causes of chronic cough with a normal chest X-ray detailing their mechanisms, diagnostic clues, and importantly, the challenges improving causality for conditions like UACS and GERD provides that crucial granular understanding needed for effective clinical detective work. It's often a process of systematically considering and, where possible, objectively testing for these usual suspects, right?
Absolutely. It's methodical work.
So we've identified the common causes, particularly when the chest X-ray is normal. Now let's pivot to how we actually treat these conditions, and crucially, what happens when those targeted treatments aren't successful. How do you approach treatment?
Well, the source explains that the approach to treating chronic cough, especially after a normal chest X-ray, is often empirical.
Meaning you treat based on your best guess.
Essentially, yes. Therapy is initiated based on the clinician's assessment of the most likely cause or causes, guided by the clues from the history, the physical examination findings, and any objective testing results like spirometry or FeNO. You're treating your best guess, or perhaps treating for the most common possibility sequentially, or sometimes even simultaneously if more than one seems likely.
Let's look at how some of these common causes are treated empirically based on the source. For postnasal drainage or upper airway cough syndrome, what's the strategy?
Therapy there is directed at the presumed underlying cause of the inflammation or drainage in the upper airways. So if infection is suspected, like chronic sinusitis, a course of antibiotics might be used. If allergy seems to be the culprit, systemic antihistamines or, more commonly now, intranasal sprays containing antihistamines or glucocorticoids are mainstays. For non-allergic rhinitis, sometimes called vasomotor rhinitis or other causes, options include things like nasal saline irrigation to wash out irritants, maybe short-term use of decongestants, or nasal sprays with anticholinergic agents like ipratropium to dry up secretions. It's all about managing the nasal and sinus condition that's thought to be triggering the cough reflex downstream.
What about for GERD-related cough? What are the treatment strategies?
Strategies for GI focus primarily on reducing the amount of acid reflux or mitigating its effects. This involves medications that decrease or neutralize stomach acid production. These range from simple antacids for quick relief to H2 receptor antagonists, H2 blockers like famotidine, and most potently, proton pump inhibitors, PPIs like omeprazole or pantoprazole, which are powerful acid suppressors.
Are PPIs the main treatment?
Often they're used for a diagnostic trial, yes, sometimes at higher doses than used for typical heartburn. The source also mentions additional non-medication measures that can help. Dietary changes to avoid known trigger foods, like caffeine, alcohol, fatty foods, elevating the head of the bed, or using wedges during sleep to use gravity against nocturnal reflux, and sometimes medications to improve gastric emptying, or agents like alginates that form a physical barrier on top of stomach contents to impede reflux flow.
And for cough variant asthma or eosinophilic bronchitis, how are they treated?
These conditions, both characterized by airway inflammation, specifically eosinophilic inflammation, typically respond very well to inhaled glucocorticoids. These directly target and reduce that underlying inflammation.
So steroid inhalers are key.
They are the mainstay, yes. For cough variant asthma, intermittent use of inhaled short-acting agonist bronchodilators, like albuterol, can also provide quick relief if there's any associated bronchoconstriction causing cough. But the primary long-term treatment is the inhaled steroid to control the inflammation. And as we mentioned, eosinophilic bronchitis is effectively treated with inhaled glucocorticoids alone.
Now, this empirical approach is common, but what happens if you've treated for the most likely causes? Maybe you tried nasal steroids for UACS, high-dose PPIs for JERD, inhaled steroids for possible CVA or EB, or you've done the appropriate testing to exclude them, but the cough still persists. What's the next step then?
This is a key point. According to the source, if a patient's chronic cough does not respond adequately to trials of therapy for the common causes, or if those common causes have been reasonably ruled out by objective testing where appropriate, like a negative methylcholine challenge, the next step is typically to obtain a chest CT scan.
A CT scan of the chest. Why?
The reasoning here is that chest CT provides much higher resolution imaging than a standard chest X-ray. It can detect subtle structural diseases or less common conditions that might be causing the cough, but were completely missed on the plain film.
What kind of things might the CT show?
The source lists examples of what a CT might reveal in this scenario. Small airway tumors that weren't visible, early interstitial lung disease, subtle scarring or inflammation in the lung tissue, bronchiectasis, damaged dilated airways that wasn't obvious on the X-ray, or perhaps atypical mycobacterial pulmonary infections, which can cause chronic cough and subtle CT findings.
So the CT is a crucial step up in imaging when the common things aren't the answer or the empirical treatment fails. What if, after this comprehensive workup, you've done the history, the exam, maybe spirometry, checked oxygen, and now even the chest CT, everything comes back normal?
This is actually a relatively common endpoint, and the source makes a vital point for both the patient and the clinician here. Patients with chronic cough who have a normal chest examination, normal lung function tests, including spirometry, normal oxygen levels, and a normal high-resolution chest CT scan can generally be reassured about the absence of serious underlying pulmonary pathology.
And why is that reassurance so important? What does it mean?
For the patient, it can significantly reduce anxiety and fear about having a major life-threatening lung disease like cancer or severe progressive fibrosis. That's huge for them. For the clinician, it's a critical milestone in the diagnostic process, having objectively ruled out the most concerning structural, infectious, and functional pulmonary diseases that typically cause persistent cough. While the exact cause might still be elusive, leading to a diagnosis of idiopathic cough, ruling out major pathology is a major step forward.
That leads us neatly to the challenging category of chronic cough, where a clear, treatable cause isn't found, or where, even after treating identified causes like reflux or UACS, a significant cough persists. This is sometimes called chronic refractory cough or chronic idiopathic cough. How is that managed? What's left to try?
This is undoubtedly an area where therapeutic options are less consistently effective, and it remains a significant clinical challenge and source of frustration for both patients and doctors. The source notes that empirical trials of various agents, things like inhaled corticosteroids, even if asthma B were excluded, inhaled anticholinergic bronchodilators like ipratropium or tiotropium, and even courses of macrolide antibiotics, which have some anti-inflammatory effects, have been attempted in chronic idiopathic cough. But unfortunately, they have not shown consistent success in large, well-controlled studies.
So throwing those drugs at it usually doesn't work.
Not reliably, no.
Yeah.
What about the medications specifically designed to suppress cough? The antitussives.
The source is quite clear, and perhaps a bit pessimistic here, stating that currently available cough suppressants are, on the whole, only modestly effective, particularly for this type of chronic refractory cough. They might take the edge off, but rarely eliminate it. Which ones are considered the most potent options available, even if only modestly effective?
The narcotic cough suppressants, such as codeine, hydrocodone, or sometimes even low-dose morphine, are generally considered the most potent centrally acting agents. They are thought to work by raising the cough threshold in the cough center within the brainstem, making it harder to trigger the reflex.
But they have major drawbacks.
Huge drawbacks. The source details their significant limitations. They commonly cause troublesome side effects like drowsiness and constipation. And crucially, they carry a substantial risk of tolerance, misuse, and addictive dependence, which makes them generally unsuitable and unappealing for long-term use in a chronic, non-life-threatening condition like idiopathic cough. The risks often outweigh the modest benefits.
What about common over-the-counter options like dextromethorphan? Is that any better?
Dextromethorphan is widely available over-the-counter, yes. It's also centrally acting, but the source notes it has fewer side effects than narcotics and is also generally considered less effective. It's thought to act at a different site within the brainstem pathways and is often found in combination cold and cough products. Modest efficacy at best for chronic cough.
And benzonatate, that's often prescribed, the little capsules. How does that work?
Benzonatate, brand name Tessalon Perlis, is described as a peripherally acting cough suppressant. It's thought to work by exerting a local anesthetic effect on the stretch receptors in the airways, essentially numbing the input that triggers the reflex arc.
Does it work well?
Its effectiveness is often variable and unpredictable, according to the source. Some patients report benefit, others none at all. It also has potential side effects, including dizziness and sometimes the sensation of difficulty swallowing or numbness in the pharynx, larynx, and tongue if the capsule is broken or chewed.
And there's a warning about chewing it.
A very important caution included in the source. Patients should never chew or dissolve benzonatate capsules in their mouth. Releasing the liquid contents directly in the mouth can cause significant oropharyngeal anesthesia, leading to a risk of choking or aspiration because the protective swallow reflex is blunted. Must be swallowed whole.
That's a crucial safety warning, and inhaled lidocaine is mentioned briefly.
Yes, inhaled nebulized lidocaine, another local anesthetic, can inhibit voltage-gated sodium channels on nerve endings in the airways and provide transient cough suppression when inhaled directly into the lungs. However, its practical utility is limited by the associated risk of oropharyngeal anesthesia and potential aspiration, similar to the issue with chewing benzonatate and the need for nebulization. Not a common therapy.
Okay. For that subset of patients with chronic cough where a specific cause isn't found, often labeled idiopathic, there's growing recognition of this idea of cough hypersensitivity syndrome, right? Suggesting the nerves themselves are just too sensitive.
Exactly. This concept suggests a peripheral and/or central sensitization of the neural pathways involved in the cough reflex. The system is just hyperreactive. Attempts to treat this often focus logically on modulating or inhibiting those overactive neural pathways.
Are there medications being explored for this? Perhaps ones typically used for other nerve-related conditions, like nerve pain?
Yes. This is an area of active research and evolving clinical practice. The source discusses findings from small case series and some randomized clinical trials exploring the potential benefit of using medications typically used for neuropathic pain or seizures. These include drugs like gabapentin, pregabalin, or low-dose amitriptyline.
Used off-label.
Used off-label for this indication, yes. The rationale is that these neuromodulators might dampen the sensitized or presumably neuropathic signaling that's thought to be driving the cough hypersensitivity. Results have been mixed but promising in some patients.
And is there a non-pharmacological approach showing promise, something besides drugs?
Yes. Recent studies have highlighted the potential role of behavioral modification techniques, often delivered by specially trained speech-language pathologists. These therapies focus on cough control techniques, identifying triggers, laryngeal hygiene, and essentially retraining the cough reflex and reducing laryngeal sensitivity.
Speech therapy for cough.
Essentially, yes. Specialized speech therapy. The source notes that while this approach is promising, widespread application is currently not practical due to the limited availability of therapists trained specifically in these techniques. But it's an area of growing interest.
Given the limitations of current suppressants and the difficulty managing refractory cough, it sounds like there's a significant unmet need for better treatments.
There is indeed a great need, a huge unmet need for new, more effective cough suppressants that don't have the significant side effects, particularly sedation and addiction potential, and the limited efficacy of currently available agents. Patients suffer a lot with this.
What are some of the novel targets researchers are exploring in the search for these new medications? What's on the horizon?
The source lists several exciting avenues of investigation, targeting different points in that complex cough reflex pathway we discussed earlier. These include the development of antagonists that block neurokinin-1 receptors, NK1 antagonists, which are involved in mediating neural inflammation and reflex activity.
Okay.
Also, antagonists targeting transient receptor protein, the phenyloid-1, TRPV1, channels those receptors sensitive to irritants like capsaicin. Blocking them might reduce sensitivity to triggers.
Right.
And the source specifically highlights a promising class of drugs, P2X3 channel antagonists. One called gefapixant has shown positive results in phase 3 trials. These target those ATP-activated receptors we mentioned earlier as key players in cough sensation.
So blocking that ATP signal.
Blocking that specific pathway, yes. Additionally, novel opioid and opioid-like receptor agonists are also being investigated, potentially hoping to find agents that retain the cough suppression efficacy of traditional narcotics, but have a much better safety profile regarding respiratory depression and addiction potential. It's about finding that sweet spot. These represent diverse strategies trying to interrupt the cough pathway more effectively and safely.
This detailed exploration of treatment from targeting specific diagnoses like UACS or GRD through the necessary workup for refractory cough, including that chest CT, to the current, often limited options for symptom suppression and the exciting search for novel nerve-targeting agents gives a comprehensive picture of the state of the art. It's a mix of established evidence-based strategies in areas where clinical practice is still evolving and significant research is desperately needed to improve patient outcomes.
That sums it up well. It's a challenging area.
Finally, Chapter 38 wisely broadens our perspective beyond the causes most commonly discussed in, say, a Western clinic, to consider global factors that significantly contribute to chronic cough around the world.
Yes, this is a critical piece of context. Absolutely essential. The source introduces air pollution as a major and perhaps often underestimated cause of chronic cough and throat clearing worldwide. Beyond just cough, it's a leading contributor to a wide range of lower respiratory tract diseases globally.
What are some of the most problematic sources of this air pollution, as mentioned in the source? Where does it come from?
The source details several important examples.
Yeah.
Smoke from burning biomass fuels, wood, dung, crop residues for cooking and heating, particularly in poorly ventilated indoor environments like homes in many developing countries. This indoor air pollution is a massive problem. Also, toxic occupational exposures without adequate safety standards or personal protective equipment in various industries. And, of course, ambient chemicals and particulate matter found in highly polluted outdoor air, especially in rapidly industrializing urban areas.
And for pollution-induced cough, are there effective direct therapeutic options? Can you treat the cough itself?
The source notes that once the cough is developed due to chronic pollution exposure, there are unfortunately limited therapeutic options available to treat the cough directly with medication. The damage might be, or the irritation ongoing.
So the focus shifts entirely to mitigating the exposure? Prevention is key.
Exactly. The main thrust of managing pollution-induced cough is primary prevention and reduction of exposure. This includes efforts to improve environmental air quality, such as promoting the use of cleaner cook stoves or ensuring proper ventilation in homes. For individuals, removing them from the source of the exposure if possible, or using appropriate personal protective equipment like effective face masks when exposure is unavoidable in heavily polluted environments.
Beyond pollution, the source highlights another absolutely critical global cause of chronic cough: tuberculosis.
Absolutely critical. The source stresses that in areas of the world where pulmonary tuberculosis, TB, is endemic, meaning it's consistently present at a high rate in the population, chronic cough is a cardinal symptom. Therefore, chronic cough presenting in someone living in or traveling from a TB endemic area must immediately raise suspicion for active pulmonary TB. It should be high on the list.
And this has significant implications for the mandatory diagnostic approach in those regions, or for patients with relevant travel history.
Yes, it mandates a specific and thorough evaluation. The source states clearly that in TB endemic areas, or with appropriate risk factors, chronic cough mandates appropriate diagnostic evaluation. This must include chest imaging, like a chest x-ray looking for typical TB patterns, and critically, sputum analysis, specifically testing for Mycobacterium tuberculosis, using smear microscopy, culture, or molecular tests.
Why is this mandatory?
It's essential not only for diagnosing and treating the individual patient effectively, but also for public health, given TB's transmissibility through respiratory droplets generated by coughing. You simply cannot afford to miss a diagnosis of active pulmonary TB presenting as chronic cough. The implications are too great.
This section is such a powerful reminder, isn't it? That the diagnostic checklist and the index of suspicion for chronic cough must be informed by the global context, environmental factors like pollution, and the prevalence of specific infectious diseases like TB in a patient's geographic location and exposure history. What might be a rare cause in one setting is a common mandatory consideration in another.
Absolutely. You have to tailor your thinking to the patient's background and environment.
Okay, we've really conducted a deep dive into Chapter 38, meticulously following the source material to explore the intricacies of dyspnea and chronic cough. We've unpacked the challenges of multifactorial breathlessness, the power and interpretation of CPAP, and the current state of dyspnea treatment, including that concept of chronic breathlessness syndrome.
We then spent significant time dissecting the elaborate physiology of the cough reflex, understanding its vital protective role, but also the serious consequences of its excess, and, importantly, the many distinct points where that reflex can be impaired, leading to ineffective clearance and risk of infection.
And we took a systematic journey through the diagnostic process for chronic cough, starting from the initial history and that indispensable chest x-ray, moving to the focused investigation of the common causes when the x-ray is normal, the ACE inhibitors, upper airway issues, GERD, cough variant asthma, and eosinophilic bronchitis, detailing their mechanisms, diagnostic clues, and targeted treatments.
We also tackled the difficult area of refractory and idiopathic cough, highlighting the limitations of current suppressants and the exciting ongoing research into novel agents targeting the neural pathways of the cough reflex. And finally, broadening our perspective to the vital importance of global factors like air pollution and tuberculosis and the etiology and management of chronic cough.
Our mission was to help you truly master this information, to move beyond a superficial understanding and grasp these topics with the kind of nuance and depth that elite professionals strive for, pulling every essential concept from this foundational chapter.
And we hope that by dissecting the physiology, the assessment strategies, and the treatment challenges for both dyspnea and cough, you've gained a profound appreciation for the complexity hidden within these seemingly common everyday symptoms.
So here is a provocative thought to leave you with, something to ponder as you reflect on this deep dive. Consider how, even with all our advanced physiological understanding of the cough reflex, our array of sophisticated imaging techniques like CT scans and objective functional tests like spirometry and pH monitoring, even with all that, the definitive diagnosis of a chronic cough still so often relies heavily on careful historical detective work, systematically ruling out possibilities and sometimes even resorting to empirical therapeutic trials because the objective tests aren't perfectly sensitive or specific in establishing causality. What does this tell you about the inherent complexity and subtle interplay of systems locked within seemingly simple everyday symptoms, and perhaps the enduring art that still exists alongside the science of clinical medicine when tackling these common problems?